Hello, everyone. Thank you very much for inviting me to speak today. So I'll be talking about the first reactive mass vaccination campaign against hepatitis E, which took place this year in Bentiu, South Sudan. So hepatitis E is a virus that exists worldwide. It is the cause of large protracted outbreaks, mostly in Africa and Asia. Are we able to change the slide, or I'm having some trouble here. Okay, so the figure on the right here shows the distribution of some large protracted outbreaks that occurred in sub-Saharan Africa in the last decade. Hepatitis E is likely the most common cause of acute viral hepatitis, causing around 20 million infections each year. 3.4 of those are clinical cases, 70,000 deaths, and 3,000 stillbirths. However, because most of these cases occur in displaced persons camps, this means that the limited access to testing and surveillance means that the true burden is likely unknown. So the virus is transmitted fecal-orally by contaminated food or water, and it has quite a long incubation period with a mean of 5 to 6 weeks. So hepatitis E disease is usually self-limiting, but in some cases causes a fulminant form of hepatitis, which can lead to acute liver failure and death. The main hallmark of epidemic hepatitis E is a high mortality among pregnant women, particularly in the third trimester of pregnancy, where case fatality risks can reach up to 25%. The infection in pregnancy is also associated with adverse fetal outcomes, including abortion, stillbirth, and preterm delivery. So there's no specific treatment for this virus. Hepatitis E control relies on water and sanitation interventions, although they are challenging and have limited impact. Luckily, there is a vaccine that exists for this virus. In fact, 3 have been developed, and only 1 has proceeded past clinical trial to be licensed. This is the Hekelin vaccine, which is manufactured in China by the manufacturer called Innovax. It's a recombinant vaccine with a 3-dose schedule. It's licensed for use among people aged 16 years and older. It comes in quite a bulky presentation. It's a glass single-dose syringe, which is not ideally suited for a mass vaccination campaign. During clinical trials, it had a very high efficacy, but as in many clinical trials, pregnant women were excluded, and this is the population that is most at risk. The vaccine itself is not yet WHO pre-qualified. However, in 2015, the WHO made its position on the use of the vaccine clear, stating that it should be considered for use in response and to mitigate epidemics, even among pregnant women. And in 2021, I'm not sure if my slides are catching up. In 2021, they again reiterated their position that the vaccine should be considered to be used among pregnant women despite limited data in this target group. Okay. So the fight against hepatitis E for MSF has been a long and frustrating one. Over the last 2 decades, MSF has been responding to hepatitis E outbreaks in IDP camps, trying to control the outbreaks in challenging conditions with water and sanitation interventions that have limited impact and few clinical management options. In parallel, MSF teams have been working on advocacy and trying to mobilize the international community to bring attention to this virus. MSF also prepared a stockpile of the Hekelin vaccine that was pre-positioned for use in response to an outbreak. And indeed, MSF proposed to use this vaccine in the last 5 years in at least 4 different outbreaks, yet repeatedly faced hesitation and ultimately was not successful in using this vaccine until now. So the vaccine was proposed for use in Niger in 2017, as well in the same year in Namibia, in Burkina Faso, and more recently also in Kuba in Sudan. So enter Bentu IDP camp, which is an IDP internally displaced persons camp in Unity State in South Sudan. It was established in 2014 as a protection of civilian site in response to the civil conflict next to the United Nations mission. The population hovers around 100,000 people and is currently 112,000. The camp has a very limited access to water and sanitation. Since its establishment, there have been cases of hepatitis E detected, and there was a large spike of cases in 2015 with over 2,000 cases. Transmission continued and has been continuing until today. So in August 2021, the Ministry of Health in South Sudan declared a new outbreak in Bentu IDP camp in response to an increase in cases. And shortly after this outbreak was declared, the Ministry of Health actually approached MSF for support in responding to the outbreak, specifically with vaccination. So South Sudan has a long experience with regular outbreaks of hepatitis E, mainly among displaced populations. One particularly large outbreak occurred in Maban, internally displaced camp in 2012, with over 12,000 cases and over 200 deaths. So the country has a long established relationship with MSF, and the vaccination campaign was able to come to fruition because of this preparedness, the local experience with hepatitis E, as well as the preparedness of MSF and support of the Ministry of Health and WHO. So this photo shows Bentu IDP camp from above. It's surrounded in brown by the floodwater, and this is where the vaccination campaign was scheduled to take place in October of 2021. And there was a slight delay due to the flooding and the flood response, and ultimately the vaccination campaign took place in March of 2022. So the target population were residents of Bentu IDP camp, aged 16 to 40 years old, which based on the most recent population census was almost 27,000 people. The vaccination campaign posed significant logistical challenge, mostly because of the packaging of the vaccine in a single dose glass syringe, which is a large volume of vaccine and indeed also a large volume of waste to manage. The vaccination campaign was implemented in fixed and mobile sites. So this photo here shows one of our nurse vaccinators getting ready to vaccinate the population in a mobile site in Bentu IDP camp. These two photos here show one of the fixed sites in one of the primary healthcare clinics during the first round of vaccination in March of 2022. And this last photo here shows 3 of our MSF staff preparing to tally the people vaccinated and record the information on vaccination cards. So the results of the vaccination campaign, the first round took place at the end of March and vaccinated a total of 24,000 individuals for an administrative coverage of 91%. The second round of vaccination took place at the end of April and vaccinated 25,000 for a total vaccination administrative coverage of 95%. And the third round is planned for September. So alongside this vaccination campaign, we're implementing a detailed monitoring strategy and operational research component, which I'll just briefly mention because it's ongoing now. So the primary objective of this operational research is to look at the real world effectiveness of the first 2 doses of this vaccine, which is normally a 3-dose schedule. So in order to do this, we've implemented clinical surveillance at the health facilities in Bentu IDP camp alongside the vaccination campaign. So since the end of March, we have recruited it's 422 suspect hepatitis E cases, which are shown in the figure here, according to age category. The blue is the number of suspect cases. The yellow shows the number of cases that were tested positive with a rapid diagnostic test in the hospital laboratory. And the dark blue line shows the proportion of cases that were hospitalized. The overall positivity is 42% for all cases. And so what's interesting and unusual about this epidemic is the proportion of cases that are children. About 59%, so 249 of these cases were less than 16 years old. And the highest rapid test positivity was 55% among children aged 5 to 9. So we also noticed that children are hospitalized at rates not much below adults. And during this time period, we have documented 3 deaths, and all of these deaths have occurred among children below 16 years old. So in the population that we've enrolled in this surveillance, we have 35% that were eligible for the vaccine. And among this population, we are conducting a case control study in order to look at this 2-dose vaccine effectiveness, recruiting cases at the hospital and controls in the community. So a second objective of the research is to look at vaccine safety and vaccine coverage among pregnant women. In order to do this, we are implementing a pregnancy census in the camp. So we are going house to house looking for pregnant women, asking them about their vaccination status, and then we will compare the pregnancy outcomes between the vaccinated and the unvaccinated women. So with the target population of around 3,000 pregnant women, so far as of last week, we had enrolled already almost 1,000 women and found a vaccination coverage of 80% with at least 1 dose of the vaccine. So in conclusion, we can say that the vaccination was feasible and accepted by the population. In fact, outside of the camp, the host population is also flood affected and experiencing cases of hepatitis E, and they're considering to implement the vaccine outside of the camp as well. We would also like to use the experience that we're seeing here from what's happening in Bentiu camp to challenge the perception that hepatitis E is a virus that mostly severely affects adults, because we are seeing quite a few children who are severely affected by hepatitis E. So we can think about how to best address the burden of hepatitis E among children. And we hope that the operational research and the experience from the vaccination can change the way we fight hepatitis E epidemics in the future. So with that, I'd like to just say congratulations to the MSF Switzerland, MSF Geneva team for their implementation of the vaccination, the field team in Bentiu and Juba, as well the population of Bentiu IDP camp, all of the collaborators, and in particular, a thank you to MSF OCA Bentiu Hospital team for the collaboration and support. Thanks for your attention.